Thank you very much. Really nice to be here. I always like my annual trips to Liverpool every year, and I was just reflecting when I was driving down the road. It was several years ago now when I first spoke at one of these conferences, and I remember being absolutely petrified, and I was really nervous about it, and it was quite nice to reflect back on how things changed, and now you can't shut me up. So thanks for the reference to a local media celebrity as well. I don't quite know about that. I haven't got my dates all mixed up. I'm actually going to be talking about a travel fellowship that I completed in 2015. So this was the Winston Churchill Memorial Trust that provided me with an opportunity, a once-in-a-lifetime opportunity really, to go and do a bit of research on a project that I was particularly passionate about. I definitely recommend that you check them out. Particularly if there's something that you want to go and research in another country. They provide funding and allow people to go and explore a different subject, and that will benefit the person that's going to do it and also their communities and their places of work, etc. So my project was titled Reducing Preventable Deaths Among People Who Use Drugs. Obviously I work on a project that's one of its particular aims is about reducing drug-related deaths. So whilst naloxone is an absolutely core element of any overdose death prevention strategy, there are certainly more things that we could be doing in order to reduce that toll. So I'm going to just talk a bit about the project itself, what I did. I don't think, or I've made a particular assumption that this audience isn't really the audience that I need to really sell the benefits of supervised consumption facilities to. So what I do intend to do is just look at some of the outcomes from the Sydney model and what some of their results were. Some of the myths that have come up about injecting facilities and just dispelling them, and a bit of the information about what's been going on in Glasgow, particularly around this proposal. So the project was based on the fact that drug-related deaths in Scotland are at an all-time high. Obviously, in the particular year that I went, we were looking back at the deaths from 2014, where tragically 613 people lost their lives, the highest that we'd ever seen. And 2015's figures have been no better, and 706 people died. So this was based on it being its highest ever, and then of course tragically that number has continued to increase. I always like to take a moment to remind us that these are overdose deaths only. So these are not deaths from bloodborne viruses, bacterial infections, road traffic accidents, violence, anything else to do with drug use. These are purely overdose deaths, so on the whole means they're accidental and therefore preventable, which is an absolutely horrific consideration. So the project itself was based on 3 areas. So the fact that older drug users are at higher risk of overdose, and of course we talk about older drug users being age 35 plus, which is by no means old. Witnesses are generally present when somebody dies, and the fact that treatment is a protective factor. In Scotland, the majority of people who die from a drug-related death are not in treatment at the time of their death, but have been in treatment or in contact with services within the 6 months prior to their death. So the structure of the fellowship then. So I wanted to do quite a lot of preparatory work before I actually went on the trip in the first place. It was really important to me to engage people in the project before I went, so that people had that kind of buy-in and they felt that they were really doing it with me, and I was able to use their feedback to find out particular things while I was away. So firstly I needed to establish, right, where do I want to go? So at first, when I was trying to work out my trip, I basically had a round the world trip. I wanted to do everything and go everywhere, and I needed to be kind of realistic and just focus it down to one area. And apart from the obvious benefits of the draw to go to Australia, I already had quite a few good contacts there. So I had previously met Dr. Marianne Johnsey, who's the clinical director for Sydney's Medically Supervised Injecting Centre. I had met her at a conference, and I'd been lucky to be involved in the WHO guidelines on opiate overdose in the community, and I had met a few other colleagues from Australia there as well, Professor Paul Dietz and Simon Lenton. So I knew they would be really good in helping me try and organise visits and arrange where I was to go. So firstly, I put together a really quick survey monkey, and it was an opinion survey on drug consumption rooms for Scotland. I circulated that over the course of 2 weeks, and it got over 400 responses. So I was really pleased, and thanks to anybody in the room that also contributed to that. Overwhelmingly positive response for these services to be provided. people who weren't too sure about whether they should be introduced, it was mainly because of a lack of knowledge about what they actually involved. Overwhelmingly, the support was that they should be also introduced in Glasgow, and that Glasgow would be most in need of these particular services. The survey also included questions, so people could give me their questions that they wanted answered while I was away, and this also formed a lot of the discussions that would take place with some of the key stakeholders that I met with in Scotland. So I met with politicians, I met with the Minister for Community Safety, I met with the Crown Office, I met with Public Health, Police Scotland, Drugs Policy Unit, Scottish Government. I met with absolutely everybody that I could think of that might have an opinion or a potential decision-making factor. So those meetings went really well. I also met with John Campbell, who's here and who's the Injecting Equipment Provision Manager for Glasgow, to go and visit some of the public injecting sites in Glasgow City, since that had been the area that people had felt most was in need of these services. And I suppose for me, I'm talking about public injecting a lot and the risks of this. I had never really been up close and personal with a site where people were actually injecting in public. The day that we went out to visit the sites, it was absolutely horrific weather. It was really wet, it was pretty grotty. And not far from the city centre, we went just literally a 2-minute walk from the shops. And with this derelict site that was covered with injecting equipment, needles, syringes, blood, human excrement. It was absolutely horrific, and I think it was quite confronting for me, and maybe a bit naive, never been, up close and personal in that way with it. But I just felt that it was such an undignified environment, and to me it was just completely ludicrous that we're allowing this to continue, and that really we need to be doing something for folks that are putting themselves in these positions and having to inject in environments like this. So first part of the trip, and obviously us having a world-leading naloxone programme in Scotland, people were really keen in Australia to hear about the project, and so it was nice to be able to share that information as well. So I did go to quite a few conferences and talk while I was there. So they had the Centre for Research Excellence in Injecting Drug Use colloquium. I went to lots of different services there and meetings. I met with Justice Health to try and help them look at introducing naloxone via their prison service. So those meetings and service visits were really, really good for me for part of the trip. And then I was nipped over to Malaysia for the International Harm Reduction Conference and did a presentation on naloxone there. Then I was back over to Sydney, and I spent 2 full weeks basically volunteering from 9 in the morning till about 6 in the Supervised Injecting Facility every day, nipping out to go and meet with key stakeholders that had been involved in the setup of the centre and that had been involved in the ongoing development of what was happening there. And I'm going to talk about some of the outcomes that they've seen from the Sydney Injecting Centre. I've visited drug consumption rooms before when they've been closed, before anybody's been in them. So to actually see this service operational and people coming through the service was really fascinating for me, and that was where I got the best experience of the entire trip, was from seeing that practical hands-on work, speaking directly with people who were using the service and finding out the benefits for them about why they come there. So really, really fascinating time there. And then I went over to Perth to the Australasian Professional Society on Alcohol and Other Drugs conference and visited some more services there. So throughout the course of the whole thing, it was a really busy 6 weeks, so got loads of information to bring back and hopefully answered all the questions that people needed me to answer while I was away. I produced a report from it, and it had 3 key recommendations. The first one was about supervised injecting facilities, and that really anywhere where there are significant numbers of people injecting in public, there's a clear need for these facilities. Of course, I had to mention about take-home naloxone as well. It should be widely available free of charge to anyone who's likely to witness an overdose. And the other one really for me, just going by the key things that we know from our drug-related deaths, is that we need to get much better at actively engaging and retaining people in treatment services when they need it. Where are all the low-threshold services? So we need, this thing about discharging people for what's deemed to be non-compliance with the service's expectations needs to stop, and we need to get real about what we're doing with our treatment services. I have some really heated discussions and training about that. It's quite an interesting one, and it's probably one for another day. but obviously quite a relevant topic. So, of the 90 facilities that exist all over the world, supervised injecting facilities are nothing new, and thankfully there are no less than 135 published research papers on the subject showing the clear evidence for these services. They've been around for 30 years. They all have similar outcome bases, so I'm just going to go through some of them and some of the results from the Sydney model. These statistics from Sydney are up till May 2015, so the numbers will have increased since then. So obviously trying to reach as much as of the target population as possible. At the time, 15,000 people had registered at the injecting centre in Sydney, and about 70% had never accessed any local health service before, so what we would deem to be our traditional services. So I find that quite an impressive statistic, that they were really having a huge reach into communities of some of the most vulnerable and marginalised people. To provide a safe environment that enables low risk, more hygienic drug injecting. So they'd supervised almost 1 million injections. The number of ambulance call-outs in the area had reduced by 80% since the service had been operating. And they'd provided over 62,000 medical and support services on site. So really nice to see people be able to come into a service and be a bit concerned about a wound they might have, nursing staff on site to be able to deal with that immediately. To reduce morbidity and mortality, so they'd managed almost 6,000 overdoses without a single death. And there have been 0 overdose fatalities on site since the centre opened, but anywhere in the world there has never been an overdose fatality from any service, supervised injecting facility anywhere in the world. I mean, that's just quite incredible. Certainly, from my perspective, I witnessed many overdoses while I was volunteering in the service. They were dealt with promptly, with dignity and respect, and certainly it was quite a life-saving moment, I suppose, for me to see that massive impact that these services can have. To stabilise and promote the health of service users. So every year, more than 2,000 individual nurse and support services are provided on site at the service. And almost 12,000 referrals have been made connecting people to health, social and welfare services. So they would have, in stage 3, the injecting centre, they would often have people doing in-reach work and doing work on homelessness and welfare services and stuff, and people really engaged with them doing that. And then, of course, the other one is about reducing public drug use and associated nuisance. So no centres across the world report any increase in acquisitive crime. Discarded injecting equipment reduced by around 50% in the vicinity of the injecting centre. And that had, despite what the media might have told you or might have alerted you to, they actually had strong support from local residents and businesses. Normally when you get 1 or 2 outspoken opposers, they dominate the headlines in the papers, as we all know, and actually they had really high support from local residents and businesses, and that's grown over time. So moving on to some of the myths. So these were some of the questions that were asked in my survey before I went. So people had concerns about these various issues. So their SIFs, supervised injecting facilities, do not encourage increased drug use or initiate new users. They don't perpetuate drug use by providing better conditions. They certainly don't undermine treatment goals, and in fact the evidence shows that the more time somebody attends an injecting facility, the more likely they are to go on and get help, receive treatment, look at different programmes. And they don't attract drug users or dealers to the area. Supervised injecting facilities are placed in an area where these things are already happening. So really the message is that if we're already providing people with sterile injecting equipment, knowing that they're going to use that to inject drugs, then we should be providing people with a sterile environment in which to use. It just makes sense. So, during the time, how am I doing? 30 seconds. During the time when I was away doing this trip, there was some work taking place concurrently in Glasgow. They produced a report, Taking Away the Chaos, and real credit to the authors of that report, Dr. Emily Tweed and Mark Rogers, who put that together, and congratulations to everyone who was involved in the work that took place to get that report live. So what had happened was, firstly in 2005, during the time while I was away, there had been significant increase in HIV in Glasgow. generally they would have about 10 new cases every year. In that particular year there was 47 new cases. So this was mainly from people sharing injecting equipment, people injecting in public. It's estimated that there are up to 500 people injecting in public, and the report that they put together provided 7 recommendations. It was published in June. 5 of the recommendations related to improvements with existing treatment services, existing services. 2 of the recommendations were brand new, and they were for supervised injecting facility and heroin-assisted treatment. So a short life working group was put together to look at those 2 particular recommendations and how that could be pushed forward. That proposal was going to the Integration Joint Board, which is the Health and Social Care Partnership Decision-Making Board, and it went to them on the 31st of August, and the initial proposal has been approved to allow the development of a full business case to look at a co-located, supervised, safer consumption facility and heroin-assisted treatment. So it's actually really exciting times just now with that proposal being developed. And certainly we would hope that that will be acknowledged, and that in February, when that goes back to the Integration Joint Board, that would be signed off. So of course there are different challenges that we will need to overcome in order to ensure that happens. We have a fairly unique legal system in Scotland where we could potentially have guidance from the Lord Advocate to allow us to legally operate such a service, but that's all work that still needs to be taking place. And obviously I'm sure people will have questions about the detail of that, and I'm more than happy to do that when we get to questions. So thank you very much.